Hello everyone, welcome to another video from Bun Med where we discuss concise medical knowledge you can fit inside of a bun. Today we will be discussing the disease profile for sickle cell disease. So let's start by thinking about how we can classify hemolytic diseases, and here are the following examples, which we'll look at in this video. Now when it comes to problems with hemoglobin production, we have conditions like sickle cell disease. And this is classified as a hereditary condition that's non-immune and intravascular hemolysis. So looking at the disease profile in more detail, this is an autosomal recessive disorder, and it occurs because of a missense mutation. So what I mean by that is that we have one DNA base being replaced by another. And so what it results in is the amino acid glutamic acid being replaced with valine. And this affects chromosome 6, and it's known as a non-conservative mutation. So what I mean by that is that we have glutamic acid, which is hydrophilic, and valine, which is hydrophobic. And because these two have different properties, it's known as the non-conservative mutation. And in this case, it's the beta-like chains that are affected. So if you remember, adult hemoglobin has 2 alpha chains, 2 beta chains, and so we have the beta ones affected here. And so if that one gene is affected, then it's written as HBAS, and if both are affected, then HBSS. And patients who have sickle cell disease do also typically have some malarial resistance. So if we look at the symptoms, again, we're going to have symptoms of hemolytic disease, including anemia and jaundice. However, there may also be additional symptoms like triggers, for example, such as infection, which will result in hypoxia. And hypoxia is an important trigger for the sickling, which occurs of red blood cells. And other being things like, for example, going high up a mountain where there's less oxygen, and so the patient would need to be made aware of this. Now, what do I mean by sickling exactly? Well, if we look at the investigations, first of all, we can do a hemoglobin electrophoresis because, of course, these patients have abnormal hemoglobin levels, and so this would be able to identify that. Again, we can do a full blood count and a reticulocyte count, and on a blood film, we will see these, which are known as sickle cells, and they get their name from the tool. So hopefully you won't forget that. And essentially what happens is under hypoxic area, when the patient becomes hypoxic, then the red blood cells lose their shape, become these sickle cells, and it can lead to a number of complications, which we will have a look at on the next slide. We can also do hemoglobin solubility testing for a more definitive diagnosis. And again, the Coombs test will be negative because there are no antibodies targeted against the red blood cells. We may also see a couple of other things. So one of the issues with these sickle red blood cells is that they can start to conglomerate, and they can essentially block off blood supply to various organs. And one of those organs is the spleen. Now, if we go back to our previous video, you may remember that we have something known as a leukoerythroblastic film, which we might see for hemolytic diseases. And this is because we have the large amounts of red blood cells being destroyed, and the body is trying to churn out as many red blood cells as it can, and these may not be as very good quality. And so we have red blood cells with nuclei, and this is seen on the image shown on the left-hand side. We also have these 4 unique-looking red blood cells, which I'll talk through now. So, as I mentioned before, there's an issue with the sickle cells because they can block off blood supply to various organs, one of those being the spleen, and it can lead to an issue where we have hyposplenism. And when we have hyposplenism, there are a certain amount of interesting things we can see on a blood film. So if we start from the top left corner, we can see that this is demonstrating a Howell Jolly body. So that's the first thing that we might see. The picture next to it is showing an acanthocyte, which is similar to an echinocyte in that it's a sort of shrunken red blood cell. And then the other 2 things we may see are Pappenheimer's bodies shown on the left bottom side, and target cells shown on the right. And so when you're approaching an exam question, these may be some of the findings to look out for. Okay, now let's look at the complications of sickle cell disease. And essentially, as I talked about already, the first thing to think about are the thrombotic crises. And essentially, we have these sickle cells, and they can lodge and block off areas of blood supply to organs around the body. So, for example, they can affect the brain, leading to strokes. They can affect the peripheral limbs or the hands and the feet, leading to hand and foot syndrome. They can block off blood supply to the kidneys, leading to acute kidney injury. And again, as I mentioned, with the spleen, we can block off the blood supply to the spleen, causing hypersplenism, and in more severe cases, an autosplenectomy. And if it affects the lungs, then we have acute chest syndrome. And finally, priapism is another problem, which is where there's prolonged painful erection as a result of the blood supply being blocked off. The second type of crisis is a sequestration crisis, and this is thought to occur when the sickle cells block off drainage of a vein, for example, of the organ, and those organs, usually the spleen, start to pool up with blood. And instead of getting hyposplenism, we end up getting organomegaly and splenomegaly, and this will be coupled with anemia and reticulocytosis because, again, the body's trying to counteract that drop in red blood cells. Similar to hereditary spherocytosis, we may also have an aplastic crisis. And again, this can be related to parvovirus, but also folate deficiency may also cause an aplastic crisis for sickle cell disease patients. And in this case, the difference here is that the reticulocytes are actually low because the body is not able to produce them. And so you can differentiate between a sequestration crisis and an aplastic crisis. Interestingly, it's actually quite self-limiting, so usually it improves within 2 weeks or so. And also, the patients might need, in some cases, require some supportive care, but although it's typically improves on its own. Now, when it comes to the treatment of sickle cell disease, again, we're going to be focusing on educating the patient and trying to prevent things from happening in the first place. However, we may need to give them oxygen and fluids because dehydration and hypoxia are important triggers of sickle cell crises. If they do develop crises, we can give them medication to try and reduce their pain. And of course, we'd need to still consider giving them vaccinations for their splenectomy and also antibiotics if they develop infections as well. They may require long life blood transfusions, but of course, it's important to think about iron overload in these circumstances, and so we may need to give them chelating agents like deferoxamine. Gene therapy and stem cell transplants may be other options, and then we have medications such as hydroxycarbamide or hydroxyurea, and this essentially increases the level of fetal hemoglobin, and so it reduces the amount of sickling because it's trying to prevent that hypoxia from happening in the first place. So that's everything for today. Thank you for watching the video, and feel free to leave any questions or comments below. Otherwise, it would massively help us if you could like and subscribe to the channel. See you next time.